Pelvic organ prolapse is a general term that refers to the protrusion of pelvic structures through the vagina in female patients. We generally like to categorize them as anterior, posterior, and apical compartments. There's 3 areas of the vagina itself that tend to be affected by this. If the bladder, or the area of the bladder that sits above the vagina itself, if that's what bulges down, that's what we call the anterior compartment, and oftentimes referred to as a cystocele. If it's on the posterior, the bottom wall of the vagina, where the rectum is behind that, that's oftentimes referred to as a rectocele, and it causes a bulge posteriorly. When the uterus itself or the top of the vagina in somebody who's had a hysterectomy, when those prolapse down, that's what we refer to as an apical type of a prolapse. All of these things can be seen together or individually, and there are different treatment options based on what the problem is. Pelvic organ prolapse probably affects about 50% of females in the United States. It may not be severe enough to require any type of surgical approach, but at least 10% of women end up having some type of surgical treatment for their pelvic organ prolapse. Pelvic organ prolapse is a multifactorial problem. It can be for a variety of reasons. What we see most often is people who've had vaginal deliveries are going to be more susceptible to pelvic organ prolapse than those who delivered only by cesarean section or who have never had a delivery. The aging process also plays a role. When women reach menopause, their estrogen levels decline, and what happens when estrogen goes low is those pelvic structures become a little bit thinner, a little bit weaker, and oftentimes can stretch out to the point where it may result in pelvic organ prolapse. We see a lot of patients come in with pelvic organ prolapse that have stress incontinence type of symptoms. Sometimes they have urinary retention where they're unable to urinate very well, or they can't empty their bladder completely. A lot of the pelvic organ prolapse, when it gets to a certain degree, will cause a sensation of something protruding or bulging at the vaginal opening. Sometimes patients' spouses will notice it, and they comment to them that there's something there that shouldn't be there. Oftentimes patients will actually feel something in that area and even look with the mirror and notice that there is something that's protruding or something that's very noticeable that they hadn't seen before. Diagnosis of pelvic organ prolapse is typically made with a pelvic examination in the office. Although a routine pelvic exam may not necessarily pick up a prolapse, going through some maneuvers may help show the physician that there is prolapse going on. That can include things like having patients bear down during their examination, examining them in a standing position and having them bear down. Because oftentimes people will complain that if they're lying down, they feel just fine, but when they're standing or doing things on their feet, that's when it becomes more noticeable. Because of that, we find that that's oftentimes helpful to do the examination in a standing position. The complaints that people have when they come in is oftentimes bulging, protrusion, heaviness, just a pelvic pressure, and that oftentimes clues us in that this may be one of the problems to deal with and we should examine them appropriately. In general, we counsel patients that there are 3 or 4 different approaches you can take when you have pelvic organ prolapse. The first thing is that just what we call a wait and watch approach if it's not very severe and if patients have relatively minimal symptoms. One of the things we know is this is not a condition that would cause any harm or shortening your lifespan or anything of that sort, but it can be very inconvenient, it can be very uncomfortable. Because of that, if we are at a point where people are experiencing discomfort on a regular basis, we generally discourage the wait and watch approach, and then we step forward and go into the potential for pelvic organ prolapse treatment in physical therapy. And there are pelvic physical therapists that we utilize and we refer to that teach patients how to basically strengthening the muscles and the tendons and the ligaments in the pelvic region that may help improve the support of those organs so hopefully they don't have as much symptoms related to the prolapse itself. Generally that works well if it's a relatively mild prolapse, but once we get past a certain point, what we refer to as a grade 3 or grade 4 prolapse, most of the time those are patients that are good candidates for surgical treatment. There's a variety of different surgical treatments that are available, some of which are minimally invasive, some are more invasive, some are a vaginal approach, some are an abdominal approach. But one of the most important things that we do is to counsel patients about what all these different approaches can be, what the risks and benefits of each are, and help them make a good decision in terms of the proper treatment. Pelvic organ prolapse surgery itself is relatively difficult and unique in our specialty of women's health care. Because of that, it's a good idea to see someone who's experienced in doing these types of procedures, who has a number of these procedures under their belt, so that they have encountered different types of scenarios or situations that may help them work through potentially problematic surgeries itself. The other is that the specialists who do a lot of pelvic organ prolapse surgery are also better equipped to assess the degree and the type of prolapse that's occurring, and perhaps even counsel patients properly in terms of alternative ways to treat it besides surgery.